Hello, ladies and gentlemen, friends, colleagues. I hope you can hear me. Um, we're excited to once again meet on this World Theragnostic Day on the 31st of March this year. So we are really excited that all of you can be here on behalf of Warmth, the governing body, the Friends of Warmth, and everyone else, including the person that has put this. As you can see at the bottom of my screen, the COO, Josh. We are really excited that we could have this wonderful day today. We are really going to have an excellent session by virtue of you all are familiar with our executive body. Please, as you can see, there are names there. Go to our website to get the details. This obviously emanates from 1941, 1994, 2021, when we have really milestone changes. And in all of this, I think our speaker has been involved as a chair. But just to remind the Warmth friends that from 1 to 4 May this year, we will have our International Conference Center in Accra, Ghana. It's a wonderful place, wonderful people, and really you're welcome to be there. Please submit your abstract. We have extended the abstract submission by a week, so you can still submit them. And those abstracts are going to be published in the World Journal of Nuclear Medicine. And just to let you know that this is a good journal, and it's the impact factor is expected in June this year. Really, you're welcome because your abstracts will be there. And then after this meeting, we have even an excellent meeting again, the post-congress meeting in Kumasu, in the Hope of Exchange Hospital, which it's again a good showing of warmth for the people of Ghana. And again, to emphasize that this ICRT is going to really showcase what Ghana and people are going to be receiving from Warmth, and all of you as friends of Ghana. So now to go to the conference, today we are excellently welcoming our friend and expert, a globally renowned friend, Frederik Giesel, who is from Dusseldorf as the head of nuclear medicine department there. Prior to that, some of you will know him as being the vice head at Heidelberg Hospital. Freddy, you have seen his CV. I'll not go through it, but I am sure you know that, I mean, nuclear medicine today, it's a highlight and people are speaking about it, from starting with the days of just imaging with the PSMA from the gallium to the fluorine labeled, and of course with FAPI as well, as you can see. And really he has been involved as a pioneer in all of the steps, and we are fortunate that we can have one of the people that are really in the pioneer, in the founding of the things, really speaking to us. And I urge you to really engage with him after he finishes presenting his excellent presentation, because when we speak about FAPI, really it's an equivalent of speaking about Freddie as well. I mean, he is an excellent speaker as well. Not only is he an excellent scientist, we are looking forward to his talk. And without taking your time, I'm handing over to him. Please look at his bio. As I say, one will not want to waste time on that. Freddie, you are welcome. And if we can ask you to start sharing your screen, thank you.
Thanks, Mike. Thanks also to the organizer, to Worms, and I'm really be honored to be part of this exciting day today, the exciting days that will come in the future, and of course that we have already achieved in the past. And here shortly my disclosures. I will directly dive into the topic of FAP, which I think is a major exciting new area beyond PSMA, DOTATOC, and CXCR4 and other targets. I think exciting time also for nuclear medicine. I want to share with you what really is of FAP about talking about some backgrounds, basic and preclinical results, but mainly also achievement, not only from Heidelberg, not only from Europe, but around the world, what's really here driving FAP into the clinical arena. As we all know, thyroid is one of the most important some kind of areas in nuclear medicine in the past. Then, of course, with FDA approvals for our other orphan drug, neuroendocrine cancer, DOTATOC, belongs to our services in clinical routine. And even then, in the last 8 years, more and more around the world, prostate cancer and PSMA has been a major change in nuclear medicine and has driven a lot of uro-oncology patients into our services, and also on strong support in big industrial players. We have now even a drug for therapy that is approved, Pluvicto, in United States and also in Europe, and it's coming more and more in other countries too. So exciting time to be in the theranostic part. But even beyond that, I think FAP as a pan tumor tracer, not a single cancer, it is a pan tracer, and even beyond that is a very exciting target to explore and also to see impact in patient care using FAP for imaging, but even beyond. And this is a reason also that Frontiers in Oncology has been stating that FAPI PET CT as cancer imaging, it might be a potential novel molecule for this century. And I will, or at least I share this mind stream of that statement, of course. And you will, at latest after my talk, I hopefully a lot of people are also sharing that kind of vibration. Of course, cancer and global cancer diseases are increasing also in the next coming decade, as you see here, worldwide. And this also implies what kind of sub-entities are belonging to this kind of burdens in getting older or aging diseased situation. And one, of course, is prostate cancer. And we look precisely to that FDG as a main kind of tool for OncoPET. Prostate cancer is not going to really work very well, but PSMA, but in FAP, it is not really also working well. However, head and neck, it's slightly working better, but also brain lesions not really working well. In thyroid cancer, multiple myeloma or lymphoma, it has been shown in studies that it's not been really perfect using FAPI PET. But however, in a majority of diseases like lung cancer, breast cancer, gastric cancer, pancreas cancer, colon cancer, and particularly also ovarian cancer, very challenging to detect, and also M+ situation, very challenging to rule out, FAPI will play an important role. Beyond that, the situation of peritoneal carcinomatosis in several diseases also FAP has been showing in the past in case representations published in radiology and other high impact journals, that this is also something to really apply in clinical applications. If we look to the incidence of global cancer statistics, it is obvious that there are certain entities has or are leading causes of death. And it was interesting to see in this exploration that all of these major leading cancer majority diseases are also better diagnosed with FAPI PET in a smaller and larger cohort using FAPI PET compared to FDG. And I share with you these cases today. However, if we're going a little bit backwards and looking about what is FAP and what we are addressing with FAP in molecular imaging, we have to understand that we're talking about tumor microenvironment. So that means we are not talking about specifically of cancer cells and cancer growth per se. We are talking about the modulation when the cell cluster are getting larger and need supportive cells, like particular fibroblast, immune cells, endothelial cells, or even stem cells. And the stroma seem to be a very important kind of shelter for cancer cells to really make this tumor kind of stiff, so that also drug delivery getting more challenging than before. So one of these driving factors of the stiffness of fibroblastic activity seemed to be not cancer cells itself, it seemed to be cancer-associated fibroblasts. And these cancer-associated fibroblasts are, in the English word, being abbreviated as a CAFs or KAF. So these are a very important cornerstone in the tumor development and tumor growth. They have a specific matrix, and they seem to be also promote cancer growth and impact in patient survival. So it seemed to be that at a certain size of cell cluster, there's a driving mechanism, and this has been already identified called TGF better, and TGF better stimulating this fibroblast and even converting the fibroblast, which means converting the good guys into the bad guys, as you see here at this graph. And also what is also going then as a kind of vicious circle, as an evil pathway, it's also triggering different kind of mediators like TGF-beta and immune modulations like interleukins, etc. So all this downstream to have an easier pathway for cancer growth, and that makes all of this so-called the cancer-associated fibroblasts as an important cornerstone, and seem to be also maybe a situation where we can address, not only identify, but also maybe treat and have a target in addition to cancer cells. When these kind of driving factors of TGF-beta is taking place and the investigation, basic science has a common kind of ground and understanding that if the cell cluster is around 2 to 3 millimeter, then it's a kind of cell pressure, genetic pressure, and epigenetic kind of conversion that suddenly interleukin and TGF-beta is being emitted to stimulate the fibroblast and even convert the good guys into the bad guys. And this has also been confirmed in several also review articles that they seemed, in addition to the cancer cell, that the CAFs seem to be orchestrating the composition of malignancy. Here's a review article that we have been collecting and sampling to really also investigating what is at the moment the state of the art of FAP in the regard to malignant and non-malignant diseases, and maybe interesting to you to look at. However, still, even of the excitement, I like the statement of Pete Schoike from the NIH, who is the director of the molecular imaging program there, that he stated in the FAP, do we know what we know now and what we need to learn? And I think we also are in the momentum of also learning on a daily, weekly basis more and more about FAP imaging, and also diagnostic performance. If we go a little bit backwards of the history, in 2017, some around, we in Heidelberg also with a group of Professor Haberkorn, and I want also to really quote here, people and scientists like Anastasia Loktev and like Thomas Lindner, Walter Mier and Clemens Kratover and others, has been really, and myself, focusing on translating this first kind of small peptides that has been showing promise results in detecting on an imaging model here, on an animal model, the fibroblast into patient care. And what we are doing when we have to translate that, we have to confirm and we have to then also compare that to standard imaging modality, at least also for nuclear medicine. Our standard imaging modality for OncoPET, of course, is FDG, like it has been now 14 years in clinical routine. So our tracer for high uptake and high metabolic rate, as you can see here, in varieties of patients. What is really obvious, that some of these cancer subtypes are even very good and very well used in detecting the cancer and local disease or disease spread, but some of them are even maybe challenged, like for example pancreas cancer, where we do know that there is hardly any kind of impact using FDG in staging pancreas cancer using FDG. How does it look like if we then apply this with this new imaging modality or this new small molecules like FAP ligands? And this was really striking also for us at that time, that we had the impression that you see most of the cancer growth in cancer diseases like esophageal cancer, as you see here, or lung cancer, and pancreas cancer. All of these can be nicely described and depicted also by the FAP imaging PET. The only thing that you have to also consider and to understand, the upper row, we see just metabolic uptake of glucose, while the lower row, we see clearly only the address, the CAFs or the cancer associated fibroblast or fibrotic activity. So even it's looking similar from the contrast, we have different information that we see from the lower row than from the upper row. One of the first prospective comparison of the standard working horse, so to say, FDG to DOTATalk FAPI PET was this work from China, who investigated several various of cancer subtypes in patient and even has been confirmed with histopathology, so rebiopsy, some suspicious lesion, to really have a valid kind of outcome and understanding what we see with FDG compared with FAP. And one of these case of this publication seen here as a lesion in the liver, and also what you see nicely, it is really strongly depicted by the FAP imaging, hardly been even seen by FDG. So therefore, they concluded at the final outcome of over 70 patients in this prospective investigation that FAPI PET showed a superior diagnostic efficacy compared to the standard FDG. So that was very striking to see in 2020. Also, our own investigation has been confirming in certain sub-cancer types that FAP seem to be even superior to FDG. Like on the left side, you see here a patient with colon cancer, on the right side, a patient with pancreas cancer, that really performing FAPI PET better than using FDG. And this case published in 2021 in JNM from our co-worker Manuel Röhrig, who also investigated very precisely the performance in a directly intraanal comparison of pancreas disease. And you see nicely here even the primary tumor in the FAPI PET not really seen in FDG. And the reason for that is that particular pancreas cancer has an overstimulation or overregulation of fibrotic activity. And this is what we can address nicely by using FAP ligand or applying FAPI PET in these patients and adding value in regard to the consideration of staging or restaging. I think most of you may even know that image. There's a reason for that is, of course, and I'm really delighted to be part of that. We have been presenting that work in 2019. Short for COVID has been all been shut down the world at the SNMMI in United States to get the image of the year for that work. And what you see nicely, that some of the diseases, as you see here, has a rather higher CAF or cancer solid fibroblast activity, and there are other tumors that has rather low CAF or cancer associated fibroblast activity. And this has been also elaborated by our imaging surrogate from PET, or called standard uptake value, as you can see here. However, if you see to the images of these three kind of sub performer in cancer solid fibroblast activity, due to this very, very low background, that even low FAP uptake or lower or moderate SUV values, that we have a very clear, sharp delineation of this tumor involvement in cancer diseases. We also have been exploring that in a multi-center retrospective trial with several centers in Germany, in addition as also centers in the United States, comparing FDG with FAPI PET. And we have been also been quite excited to see that particularly in certain areas of the body, like for example here liver parenchyma, where we usually have a slightly higher uptake in FDG as a standard physiological uptake, we have close to zero background here with FAPI PET, and therefore we can nicely depict here also lesions which are very tiny, small, which not really been visible with FDG, but with FAP has been nicely depicted. On the other hand, patients with colon cancer, where you have the bowel movement, then you have this obscure situation that you don't sometimes know, is it bowel movement or is it cancer? And you also see here with FAP, it really helps to perform and rule out if there is cancer involvement or standard normal physiological situation. So at that time, we also stated at the end of the day that FAP is at least comparable in the main kind of course of patients. However, due to the slower background, we stated that FAPI-PET is in some cases even superior. And also in rare disease, which was really striking to us, like also here, urinary bladder cancer and glomus cancer, we have been really seen a strong FAP uptake. So even in unknown cancer of unknown primary, like CAP patients, it is interesting and should be rather also considered in the future to investigate and doing their prospective trials. When you introduce a tracer that is new, we need also to confirm by structural imaging and not only by a biopsy. And it's sometimes even hard to get always biological specimens. So as you see here, this was a patient that had colon cancer metastasized in the lung and in the liver. And this was being clearly visible and being depicted by FAPI PET, as you see here in the upper row, this lung involvement in the parenchyma, but also in the liver lesion nicely depict clearly visible, but also FAPI PET has been ruled out. However, as you see here in the maximum intensity projection, you see in the lower pelvic this upregulation. This is not a tumor. This is a physiological fibroblastic activity of the uterus of a female patient. However, we have also been investigating lung patient, and it's really striking to and exciting to see that it seemed in these patients it can be even used as a one-stop shop to elaborate the brain lesions and also, of course, the chest and abdominal situation. Here, a case where ACC, a rather challenging case also to define and define the target volume definition. And here also we got the feedback that radio-oncologists appreciated very much this high contrast to define clearly the target volume definition. And you see also with FDG, it was not really helpful and even not really applicable to use in the future. Interesting using small molecules like DotaTalk, like PSMA, but also here with FAP, it is interesting that we are very rapid on the target. So when you're doing FAP imaging, it's exciting to really also have an earlier scan time. So if we introducing more and more FAP in the clinical environment, we will change our clinical processes because there's no necessary of a long uptake time, as you see here in a late stage lung cancer patients with lung involvement, but also bone involvement. And then we also will not challenged with the topic of uptake in the muscles or even that patients need to fasten in an adequate way prior to imaging. Here, the case that I mentioned before, when you have in the head and neck area challenges of kind of a background uptake with the FDG due to inflammatory situations or some muscle adjacent situation of the cancer situation, infiltration issues, then really FAP seem to be really helpful. And you see that really precise at this case here of a rather cancer rare disease. However, you see nicely this clear visible delineation of this cancer involvement and the background. So really improve also the topic of target volume definition in radio-oncology. Also, this case here, for example, in a kind of challenging cases in the colon cancer patient, TNL cancer, you see also the definition of the target was really helpful to have a clear visible of the tumor involvement. And now, going from radio-oncology, it is exciting to really see this area, I think, where FAP will be very, very disruptive. Gastric cancer, very high incidence in Asian area, where it's challenging to detect and also in follow-up cases to define if we have local or extended disease. FDG, particularly in primary staging, is not working well. CT is not working well. MR even also not really helpful. Here, a study by Peng published in Radiology showing the clear evidence of this high impact in FAPI PET compared to FDG, where lesions are clearly visible as a really extended, unfortunately, disease. Another case from that work, primary tumor, but also extension in the liver area is clearly visible by FAPI, is not being picked up by FDG, and also, as you see here, this pleural involvement. Another, and you see, I want to get you excited about really this disruptive situation in gastric and certain other subtypes. It is really seemed to be one of the application in oncology to use FAP in gastric cancer for diagnostic purposes. But also, and you saw already some cases with pancreas cancer where FDG is not very useful to apply for. You see clearly that the FAPI PET outperform FDG, and this is a study also by Pang et al. Has been showing that in pancreas cancer we even achieve higher, of course, SUV values and higher sensitivity compared to our standard FDG OncoPET tracer. In addition to gastric cancer, and now we're going into this other challenging cancer subtypes like liver cancer, HCC, CCC, we also see that FDG is not working well. MRI might be helpful, but here we see also a corner or a corridor where really FAP should be more and more applied. And here, this investigation by Pang showing also that FAPI PET is really, really outperforming our other imaging tracers in nuclear medicine. And here another case nicely matching well with MRI. So I think FAPI has also here added value, particularly also not only in addition to the primary staging, but also for a recurrent or N and M stage. This is an application and sub-cancer types in gynecology work from Heidelberg that I also supervised at that time is very, very supportive to also use in gynecology cancer patients like ovarian cancer, cervical cancer, to really use FAP. And also great work has been just out for breast cancer patients. So I do believe that FAP is also be a very good tracer for gynecology cancer patient, and that work from Daniel et al. Confirmed that, and as you see that also in comparison. This year, and I mentioned that in my introduction before, when you're talking about the situation of peritoneal involvement and peritoneal carcinomatosis, then it is very challenging to really have clear kind of robust information by FDG. With CT, of course, we have clear indirect signs like fluid or some kind of tissue plus situation. However, as you see here with this case from Chen et al. In the European Journal of Nuclear Medicine and Molecular Imaging, here, as you see, this involvement of carcinomatosis is really impressive, and the extent is very clearly visible. So I think, particularly in the M+ situation of ovarian cancer, it is very, very helpful. As I just mentioned, also breast cancer, Great work also from the Münster group has been shown that in breast cancer, FAP seemed to be really helpful in the situation of T and N and M staging, as you see here in this particular case. And FDG is, of course, of value, but I think it is also outperforming using FAPI PET, in particular in these sub lesion or sub cancer patients. In regard to the additional radioisotope, and the question is, when we are already talking about of so many sub diseases in cancer and even going beyond, and I will show you that in a few minutes, then the question is, do gallium FAPI being still the right kind of avenue to go? And this is a similar discussion or tension that we are exploring and being exposed to our situation when we have been introducing PSMA. We started at that time with gallium to get the little baby steps, but when then also the community has been really been consolidated and been clearly confessed that PSMA is the way to go, it converted from gallium into the so-to large production using F18 labeled compound. And the same thing we at least observing that F18 labeled FAP ligands might be also essential to explore and to introduce, and that is a FAPI74 that has been nicely also in courtesy to Dr. Watabe from Osaka been investigated. There's a study running a small baby basket trial of pancreas, HCC, and gastric cancer patients in a direct comparison. And you see also here that FAPI is really helpful. Another, and I mentioned here before, that pancreas is of added value, and this single prospective trial in Japan also confirmed this statement. There's still the trial is running, but now with an F18 labeled FAP ligand, as you can see here, and also impressive results compared to FDG. However, and you see, we go on and go on, and it's really exciting to share with you this kind of uniqueness and novel avenue for nuclear medicine. And here also a great work of Dr. Novaza from Dusseldorf in a cooperation with Heidelberg and Azerbaijan, and Mike Shateke from South Africa, that really here comparing FAPI and FDG in bladder cancer, you see that this is really also very helpful, and we are now looking into also prospective trial using FAPI PET in bladder cancer. And this is the statement that we are really confessed that this is superior to FDG. Exciting is also, and you remember that I stated that cancer-associated fibroblasts seem to be one big cornerstone for driving cancer diseases, driving it into the progression, unfortunately, and invading the whole human body. And there might be also a modulator to shut down these cornerstones. And therefore, we have been interested that if we having a cocktail or a systemic treatment with chemo or immune treatment, do we see changes in these FAP signal? And this is, to my knowledge, one of the first image to really show in a human body, in a non-invasive procedure, the down, so to say, regulation of cancer-associated fibroblasts. And you see here prior to systemic treatment and after initial treatment that we have a down regulation of FAP signal that also implies treatment responses. So everybody is exciting now also to go from diagnostic into treatment. And also we all, as an advocate of nuclear medicine, we, as a day of Theragnostic, we are devoted to really want to see therapeutic impact also using FAP. And we have been a little bit hopeful that it's as simple as PSMA, but we still think, I think, we need a little more lesson to learn on that. And the reason is that we are addressing not only cancer cells. We rather addressing tumor microenvironment. And even if we have here really high, inviting high contrast in also pan tumor tracer and very specific, we are addressing the microenvironment. And that means also that we might get challenged by not a clear treatment response, and we still have to work on that. But still, even we have the option, and there are also very promising targets out on that. What is also important to understand that tumor residence time and treatment regime, we need to overthink and maybe to adjust and maybe also learn from radio-oncology that we maybe do fractionated infusions like on a daily or weekly basis, like a small earthquake, to then that the whole cancer house is collapsing at the end of the day. This is a classical example here of a case that we performed in Heidelberg, FAPI-02 and FAPI-04 in the development of certain FAP derivatives. And what you see from the molecular structure, it's really looking very similar. However, due to small site changes, you see that the behavior suddenly changed in tumor residence time. And that is something that we still have to work on, because longer residence time seem to be also impacting, of course, tumor microenvironment and also then treatment effects. However, I think this is still a way to learn and a lesson that we still to learn and to explore. However, similar to other centers in the world, we see responses with FAPI-46, similar to other compounds, that we see moderate, not complete remission, but also responses and tumor control. And I think most of the patients in the late situation are first of all happy to have a tumor control, and therefore very promising first attempt. The additional case of a late stage disease, also with decline of FAP signals, so indication of tumor responding using yttrium FAPI-46. This is a case, and thanks very much from Richard Baum from Wiesbaden, is a patient of ovarian cancer with several cycles of FAP therapy. And here we see at the beginning, prior to therapy, extended kind of tumor in the abdominal region. And after treatment, you see nicely a complete remission. But still, it is a cocktail or a combination therapy and not like PSMA kind of monotherapy. So we still have a lesson to learn on that avenue. But exciting time for all of us. But going beyond on oncology, we do, and I believe FAP is a very exciting tracer in other areas beyond oncology, like cardiac, for example. First great work from the Munich group in an animal model, but this has been already been translated into human beings, and great work from the Professor Bengel's group and Dr. Dickmann, who really investigated very precise the impact of FAPI in cardiac patient, and even addressing prognostic factors in regard to FAP in cardiac patient, and got the image of the year last year at the SNNMI in Vancouver. In addition to that, systemic diseases like inflammatory diseases, and here rheumatology is a field where they are desperately also exploring the FAP imaging and also translating and modulating for therapeutic agents. And here you see nicely also first work from the Erlangen group and even on a kind of treatment follow-up, that FAP can also non-invasively give insight into the inflammatory status and pathogenesis using FAPI PET under certain treatment. And also, I think the quantification of interstitial lung fibrosis is something that is still not ruled out today. And I think it also invites to use FAP particular in regard to fibrotic modulation and treatment assessment, and also when we are addressing certain new made systemic treatments to assess fibrotic activity and, for example, decline of fibrosis, how we're going to measure this. And with FAP imaging, I think it is a really new tool to also quantify fibrosis, not only in the lung, also great work are here in liver diseases. However, we are all, and hopefully now closing more and more the door of our pandemic time of COVID-19 infection, but we will deal with long-term COVID side effects. One, of course, is associated with primarily the lung. And here also FAP can help to rule out the fibrotic and pathogenesis, and also being open and bring light into the understanding of COVID long-term effects in fibrotic activities, and maybe even help to develop here certain drugs to really have supportive care of these affected patients. For this, and I hope on this diagnostic day, it's also a window opener for exciting time for all of us in nuclear medicine. And FAPI-PET is today, has a high publication. It's increasing on a yearly basis up to now 600, over 600 publications in PubMed. You have been seen, and I shared that with you today, that FDG is, of course, our standard tracer, but FAPI can really be superior in certain subtypes and even beyond oncology. It seems to be a multi-tumor tracer, and also is open for theranostic purposes, that you have been seen as a tumor control and even beyond tumor control. With this, I thank you for invitation. Thanks for listening. Thanks for also be part of that today. And I think even beyond FAPI, we're on a very, very exciting journey. It will be sometimes maybe a not smooth ride. It will be maybe a little bit bumpy, but at the end of the day, it will be a great and exciting time for all of us. Thank you very much.
Was really beyond what we really expected from you, but as usual, you really give excellent talks, and really that shows you are again in the core of what drives nuclear medicine today, really be from prostate to now FAP. And as a global leader, we are appreciative and welcome your comments, and this was really informative. But now the colleagues are going to be asking, with this excellent presentation, now what now? As you know, WOMT is one of the organizations that try to take things like FAP to the patients, but to other corners of the world. Can we also be saying that we can explore FAP on a faster note, labeled with things like technetium, for instance, to make it available for other people? And also, as the question has been said, sometimes people don't have access to gallium-68. Can we also label it fluorine-18 FAP? And then how does it compare to gallium, both the technetium and the fluorine-18 label, as we start the question?
Yeah, so Mike, many questions at once. Thanks for your comment. And so starting first, it is being started with gallium, and there are several FAP derivatives out. And of course, there are now at least 2 or 3 F18 labeled FAP derivatives out also. What I have seen so far is that with the F18 labeled FAP, the clearance and the blood pool is more longer or prolonged. So that is something that we have to at least be considered. So also this quick kind of scan time after 10 to 20 minutes is something that we need to balance in regard to the blood pool in F18 labeled compound. In addition to that, we see in some of these derivatives also some different elimination routes like hepatobiliary routes. So this is something that needs to be also addressed in regard to what kind of tumor diseases we're investigating, such, for example, HCC or CCC are something that is still then not been applicable for certain tracers that is eliminated by hepatobiliary route. In addition to that, you mentioned technetium. I do believe that FAP technetium will be a groundbreaking new application in the field of the area where predominant gamma camera is available. The reason, as you and we all know, we have the technetium MDP for the bone kind of involvement or pathogenesis. But with FAP, we have the first time, so to say, FDG or tracer for cancer that we can stage cancer diseases in a gamma camera. And this is what I find very, very appealing and attracting. And so there are, at least so far as I know, two tracers of technetium labeled FAP out and been at least described so far in human beings.
Thanks, Frederik, for that. I think the follow-up to that, the people are asking, is the retention time going to be enough for us to really consider the therapeutic aspects? You have shown some of the example with yttrium and so on. Is it going to be, which of those is going to be the sufficient tracer for us to label with rhenium, lutetium, yttrium, or the alphas?
I think also, I think this is something where we need really core expertise on one table. What I observe also, Mike, is that we need here people who understand the physics, the radiochemistry, and also clinical application. The tumor residence time is one story, as we all know, but it's not the overall story. As we know, there are radioisotopes that are very much suitable for rather short tumor residence time, as you mentioned, like rhenium. But there's also other FAP tracers that has prolonged or long tumor residence time. So then these are rather suitable for radioisotopes, like, for example, actinium with the half-life time of 10 days. So I think we need really to get the right, so to say, the right car with the right engine. And this has not been explored in an extensive manner. And I think this is important that we all from the nuclear medicine society really get deeper into this physics and also biological pattern. And in addition to that, what I mentioned, to get the right car with the right engine, so the right shuttle molecule with the right radioisotope, we need also, in addition to ask for which cancer subtype, because we do know that we have a variety of cancer subtypes. Some of them have very high FAP expression and some of them very low. So which of these are going to pick for the treatment first? And I think you would agree on with me that you will pick first with the one promising one, which means with high FAP expression. And even cancer that is not only have cancer solid fibroblasts who are high upregulated, so maybe that even cancer cells itself express in FAP. And we do know, for example, as one example, that sarcoma has a high upregulation also from cancer cells itself. So sarcoma would be one of the first cancer types that I would jump first to explore all of these questions that I just shared with you.
Thanks for that. I think as a follow-up to this, the people are asking then, does that mean that, say, for instance, we pick up sarcoma as the community of warmth? Now, is this uptake of FAP related to the aggressiveness? Does it have anything to do with aggressive, the more aggressive it is, or not?
I mean, as you saw with this one patient who responded to treatment and then declined in the FAP signal, you can assume, due to the biology, that this is what it is. High FAP expression means also high aggressiveness of tumor, but also, unfortunately, short life expectancy. However, in this crystallized manner that we already have evidence-based studies that showing FAP and prognostic overall survival has not been done yet so far. There are exciting trials ongoing, but at the moment, to my knowledge, it's not been yet available in patients so far.
Excellent. Just related to it, like in prostate cancer, they are asking, can we go for well differentiated versus non-differentiated, for instance? Those are PSMA negative. Is this going to be the home for FAP? How does it compare in this?
Yeah, but this is what it is, you know. But we also need to really, when I see the FAP images, Mike, I always have to remind myself we are not showing we're not showing tumor metabolic rate, we're showing just fibroblastic activity, and therefore we also have to dive into the topic of something like side uptakes that has not been related to cancer, like wound healing processes, or like this female patient that I showed you. You know, so I think we all are still in the next years in this learning stage to understand what do we see and what is cancer, what is not cancer, and what is the best subtype that is most suitable to treat for.
So meaning, I think another question was saying that can it, but your opinion as they say, infection versus inflammation, we can't separate from oncology at this moment, and therefore
Yes.
the question that, yeah, okay.
I mean, the information is a question that I often get, and the inflammation, we have two processes of inflammation. One is chronic inflammation, and one is acute inflammation. And this is where we can separate. In acute inflammation, so sudden inflammation, FAP is not showing up because the fibroblastic activity has a prolonged time, a chronic situation. So in acute, we have FDG strong signal, FDG. However, when it's switching to a chronic inflammation, then the fibrotic activity is increasing, and then we have the FAP signal. But chronic inflammation is then challenged to differentiate from cancer.
Okay. No, that's really, that makes, you mentioned that gastric is going to be disruptive in a gastric space. So what can we do collaboratively in home, for instance? Is there anything you could suggest the colleagues we should, engage in this disruptive journey with you?
Can you repeat what do you mean with this?
You mentioned that in the gastric setup, it's going to be a disruptive situation with FAP.
Yes,
So,
yes, very much. I think, Mike, thanks for picking up that, and nice, thanks so much for the question and this very active interaction here together. At the end of the day, I think we will see FAP in many tumor diseases, and I will share with you what my opinion is, where FAP is a really important diagnostic tool. Pancreas cancer is not working well with FDG and other imaging modalities. So pancreas is the first choice for FAP imaging. The second, of my understanding, gastric cancer, very high incidence in Asian areas, very difficult to diagnose with CT or MR. So gastric is very promising, and FDG is also not working well. So no, we are two. The third is HCC, CCC. So hepatobiliary and cholangular cellular carcinoma. Also very challenging to diagnose with FDG or at least nuclear medicine tracers. FAPI works fantastic at what I've seen so far. So we have already 3 to 4 already where I see that is clearly superior to FDG or standard imaging modalities. And if we go on, I have always thought that lung cancer is FDG the imaging modality of choice. We have it on the daily cases here in Dusseldorf. You have it on your side also. High volume of FDG PET-CT in lung cancer patients for staging, restaging, etc. However, in one subtype of lung cancer, like adenocarcinoma of the lung, as we all know, FDG is not working well. Interestingly, great work out recently published also in radiology and also in JNM work showing that FAPI is outperforming FDG in adenocarcinoma of the lung. So we have already elaborated together at least 6 or 7 cancer entities where we have strong benefit using FAPI to compare to our standard tracers. So I believe it's very disruptive.
So in other words, just on the screen as we speak, as the colleague is asking, can we replace FDG with FAPI? Or are they complementary mainly?
I mean, it seemed to me the question, like Mike, you remember when we introduced the first time actinium, and then suddenly the question came out: can we just replace lutetium with actinium? Yeah, it's not going to happen. And the same thing I see with FAPI. We should use our drugs and pharmaceutical drugs where it's performing best, just for patient care. And that's a major focus. Patient care and high quality of services is what we are devoted for. And therefore, I think FAPI will not in generally be used as a better tracer. We have to use it in a wise manner, and then we achieve what we have to achieve.
Thanks. I think we have to then respect the time and really say thanks to you for really allocating your special time. And as a global leader and an excellent teacher, we really appreciate this. And you can expect some of our colleagues, if you allow some of our colleagues in the home community, they will be in touch with you to try and explore this further, and then so that we can take this to our patients. We appreciate this, and really we thank you so much for this excellent presentation. And then of course, you know, you will be a friend of Warmth, and we still urge all of you to really join the Ghana meeting from 1 to 4 May, and the post meeting 5 to 6 May. You're welcome to all of you, and please join Warmth. Josh is there and sending out the presentation. Freddie and the colleagues, the governing body, and friends from all over the countries. Thank you so kindly.
Thank you so much.
Thanks. Bye.